welcome once again to today's session of the EAJNS Journal Club Bootcamp. My name is Georgia Koech, and I'll be your moderator for this session, representing XYZZ Med. The EAJNS Journal Club is a collaborative initiative led by the East African Journal of Neurological Sciences, working together with JOKAP, that is the Journal of the Kenyan Association of Physicians, JOGECA, Journal of Obstetrics and Gynecology of East and Central Africa, and Annals of African Surgery, and the Anatomy Journal of Africa, in partnership with XYZZ Med, SCORI, CUMREC, and other student-led research communities. We also thank our partners, Daktari Online, for supporting this initiative and offering us this platform. Our goal through this bootcamp is to build scientific critical appraisal skills, increase engagement with local journals, and encourage early career researchers and medical students to participate more actively in publishing and peer review. Today's session is session number 8 of the bootcamp, and on the critical appraisal of a case report using guidance from JOKAP. Case reports play a vital role in medical literature. They often highlight rare conditions or unusual presentations, describe novel diagnoses and therapeutic approaches, generate hypotheses that may later be explored through larger studies. And although case reports sit lower in the hierarchy of evidence, their value lies in clinical insight, educational relevance, and contextual learning, especially within our local practice settings. Our session today will run for approximately as follows: a 15 to 20 minute presentation focusing on the selected case report, including its clinical relevance, structure, ethical considerations, and reporting quality. This then will be followed by a 20-minute open discussion where we will critically appraise the case report using standard appraisal tools, examining clarity, novelty, validity, applicability, and lessons for clinical practice. Then we will get closing remarks and expert insights from our guest editor, who is one Dr. Jeremiah Munguti, an associate editor at JOKAP. This is a supportive learning environment for participants at all levels and at all stages of their research journey. And with that, it is my pleasure to invite our presenter for today's session, Najma Aidan from CUMREC, who will guide us through the case report selected for discussion. Najma, you may proceed.
My name is Najma. I'll be presenting today's case report. So the title is Unmasking Lupus, Generalized Lymphadenopathy, Mimicking Lymphoma in SLE, a case report and a literature review. Here are the authors and their affiliations. The paper was published in JOKAP. So the abstract contains a brief overview of the case description. The case highlights that lymphadenopathy can be the initial manifestation of SLE, which may easily be confused with infection or malignant conditions. So a 25-year-old woman presented with generalized lymphadenopathy and constitutional symptoms. Initial investigations were done, and it pointed towards non-Hodgkin's lymphoma. And however, immunohistochemistry did not support malignancy, and lymph nodes partially regressed with steroid therapy. She later developed nephrotic syndrome and cutaneous features typical of lupus, and an autoimmune workup was done, and a repeat biopsy was also done, and this supported SLE diagnosis. The authors emphasize the importance of considering autoimmune cases when evaluating unexplained generalized lymphadenopathy. The introduction. SLE is a complex autoimmune disease with highly variable clinical presentations. So because its manifestation overlaps with infections like HIV and TB or malignant constitution, diagnosis can be difficult. Lymphadenopathy is one of the possible initial features for SLE, and especially in resource-limited settings where TB and HIV are common. So this makes it difficult when it comes to distinguishing autoimmune from infections or malignancies. Studies have shown that up to 69% of patients with SLE develop lymphadenopathy. Yet this feature is not included in the ACR Euler classification criteria for SLE. Histologically, the lymph nodes in SLE, they can show diverse patterns that mimic lymphoma or granulomatous diseases. Conditions such as Castleman's disease can closely resemble lupus, and in rare cases may even coexist. Therefore, clinicians must should maintain a broad differential diagnosis when it comes to autoimmune diseases. A case description. So the patient was a 25-year-old woman who presented with swellings around the neck that later spread to the axillary and the inguinal region. They were initially painful. The swellings, they become painless as they enlarged. She also had fever, night sweat, and she lost 12 kg over a period of 6 months. So previously she was treated with, she completed treatment for pulmonary TB. So when physical examination was done, she had multiple bilateral firm, mobile, non-tender lymph nodes measuring 0.5 to 2 centimeters. Well, fine needle aspiration cytology suggested a lymphoproliferative disorder. An excision biopsy was done, and it was reported as non-Hodgkin's lymphoma. She was later referred to the hemato-oncology, and she was started on antisteroid therapy. Immunohistochemistry was done, and it showed no features of malignancy, and the lymph nodes significantly reduced in size after the steroid therapy. PET scan was done, and it demonstrated FDG uptake in multiple nodal stations. The infradiaphragmatic, the lymph nodes above the diaphragm and those below, they showed FGD uptake, and this was consistent with Lugano stage 3 disease. Because of the discordant findings, a repeat excision biopsy was performed, and it revealed reactive follicular hyperplasia. Other tests were done, as tests for TB, Epstein-Barr virus, HHV, and tests for atypical bacteria like spirochetes and IgG4 were also negative. The patient later developed Malar rash. Okay, this ruled out lymphoma. The patient later developed Malar rash, non-scarring alopecia, ascites, and peripheral edema. The labs revealed severe anemia, proteinuria, hypoalbuminemia, and positive antinucleotide antibody, and all these other antibodies. And all these met the 2019 ACR Euler criteria for SLE, which is this is the criteria for SLE diagnosis. As you can see, she had almost all this. So although lymphadenopathy is common in SLE, it's not part of the classification criteria. And PET scan revealed false positive for Lugano stage 3. The histology in SLE may also mimic lymphoma, and hence repeated biopsy is important. It's important in atypical cases. Delay in diagnosis may lead to unnecessary exposure to chemotherapy, as we have seen. The patient was diagnosed more than 1 year after initial presentation. In conclusion, generalized lymphadenopathy may be the first manifestation of SLE. Clinicians should maintain a high index of suspicion for autoimmune diseases in unexplained lymphadenopathy. Early recognition and appropriate treatment lead to good outcomes and prevent unnecessary interventions. the ethical and the publication integrity. So the paper was published in JOKAP. The authors report that the case was conducted in accordance with ethical standards. The patient information were not revealed. There was no consent of. There was no conflict of interest, and informed consent was obtained. Here the conferences. Here the references that the authors use.
Thank you so much for that, Najma. Now we'll move on to the second part of the session, where we'll have Felix Njoroge take us through each session. You are once again welcomed to share your thoughts and your comments on the paper. So, Felix, welcome.
Thank you so much, Joy, and thank you, and job well done to Najma and the Kumrek team for once again supporting the initiative and doing a good, concise presentation of our paper of discussion today. And we also extend our gratitude to JOKAP, represented today by Dr. Manguti, who graciously given us this paper as part of our bootcamp curriculum. So before we get to the most exciting part of our discussions, which is always the open forums where we discuss our papers, where we discuss the paper of the day, I'd just like to share a few updates. The first one to do with the organization of the materials and the resources that you need for the course. So number one, all the resources, links, and materials that you need for your for all past sessions, they are available on the EAJNS website. A number of you have still been sending emails requesting for them. So just go to the website and there's a tab which is just written EAJNS Journal Club. You'll find it there, and you'll find a small the full description of all the past sessions that we've had from session 1 all the way to session 8 right now, as well as the reference materials, as well as the recordings as well, which we've updated. So I hope that's okay. And secondly, we'll share an updated program in terms of the timetable of the bootcamp. So we've made some adjustments, which will hopefully also make the bootcamp a bit easier for you. We'll have a 2-month break after April. So we'll have, let me just do 1, 2, 3, 4. We'll have 5 more sessions up until the end of April. And then we'll give you a break for you to catch up before the graduation. So remember, we said this course goes all the way up to June. And for us, we are very keen on all of you being active participants. And so no one will graduate or just get a certification without having completed all the reports, which is all 13. There'll be 13 in total. We're now in session 8. So you'll need to do all of them. And so to accommodate that, because we understand a majority of us are quite busy, caught up in the different commitments, both whether working or academics. So we'll have that. So we truncated it. Because some of the papers were a bit repetitive, and just to accommodate for that. So for today's discussion, we'll be discussing a case report, as you've already obviously seen. So far we've gone through cohort studies, prevalence studies, case controls, the different types of experimental studies, from randomized control trials, experimental animal model studies, quasi-experimental studies. And so for today's discussion, we'll discuss a case reports, and as Joy mentioned, they are important papers, although in the hierarchy of evidence, which some people are against, actually, they're put at the bottom, but okay, a bit lower, just above the expert opinions, but they have a lot of value in driving research and education and insights in various topics. And so for today's paper, we'd like to have another lively discussion. I hope all of you are ready to engage. As always, and be active. We strongly encourage you to unmute. And if you're not able to, raise your hand, or not, rather just use the chat box and just type in your thoughts on, or yes, as we discuss. So just, if you'd like to unmute yourself, just raise your hand and then Joy will unmute you and then you'll have the mic to talk. So I hope that's okay. So we begin. So looking at this title, what were your thoughts on it? Was it precise enough? Was it informative? Was it specific? Did it do justice to what the paper was all about? And just by reading the title, would you have a good picture of at least what the paper is all about? So you're free to use the chat box or to unmute. So you can lift your hand and then you'll be unmuted by Joy, and then we can begin the discussion. So anyone who'd like to open the discussion today?
Okay, maybe I can start. My name is Anthony. Okay, I'll discuss about the title. So the title and the author, we can see clearly it's a good title. We have authors from good affiliations. You can see it's from the Department of Clinical Medicine. And we are talking about, it clearly identifies the condition. We are talking about lymphadenopathy, mimicking lymphoma in SLE. So according to me, this is a good title because one, it identifies the condition, and then we can see there's a challenge here, the diagnostic challenge, because of the mimicking of the lymphoma and SLE. So it's like we are trying to evaluate that challenge. And then clearly it says it's a case report. Yes, thank you.
Thank you so much, Anthony, for the contribution. Anyone else would like to add on to what Anthony has said so far? And remember to introduce yourself and say your affiliation, and then you can speak. Okay, yeah, I think generally what Anthony has said, I think it's a good title. It's also a bit catchy, I think. I can see a notification. Okay, yeah. So it's just his affiliation. So I think it's a good title. It has all the main parts that we've discussed. You know, it describes a condition, and it also states the kind of study that it is. And I think that's sufficient for the discussion, and the affiliations are well and clearly stated, as well as other important metadata like the DOIs and all. So, Joy, maybe you can read the chat box.
Yes, we have a question from Susan. She's asking, why is literature review included in the title?
Yeah, thanks, Susan. I think often case reports are also accompanied by a discussion of existing literature from other parts of the world or in that particular field of that particular case. And I think maybe as we progress, we'll see what they discussed and also what NAJMA had presented. So that's appropriate, since it's not just describing what the case was. They've gone further and discussed, you know, what this means and the implications. So yes, I think that's okay. For the title and authorship, we can scroll down to the abstract. And Najma, maybe you can scroll down a bit. So yeah, looking at this abstract, is it a good snapshot of what the paper is all about? Does it have the main parts that we discussed of a good structured abstract? Does it have a background, a good description of the case, a summary description of the case, the methods they used, the a summary of the interpretation and significance, and have they also included keywords that use mesh terms? So anyone would like to contribute? Joy, you can check the chat box.
Yes, we have a response from Anthony saying it was very short.
Maybe Anton, you can expound more on what you would have liked to see, since I think, as was mentioned, for even as we become peer reviewers, it's good to give detailed, constructive feedback so that it's useful as you send revisions for as an author on what they could do better. Maybe you can describe what you'd like to see on the abstract.
Okay. So I saw the appraisal document. The key areas. Okay. They say that number one, the abstract should be around 150 words. This one I counted it, and then counting SLE and non-Hodgkin's as one single word, I saw there were only like 54 words. Then in terms of the background, I know it was stating about lymphadenopathy can be an initial manifestation of SLE, but it didn't tell us how rare this presentation can be. So we had to like go further on to the case report to get that. And then in terms of the key description, in the case description, it tells us about that 25-year-old woman with all those symptoms. The other later symptoms that were present in the case report, because they later on developed symptoms of nephrotic syndrome, Larash, just SLE. So those later features were not actually mentioned here. And then even the diagnostic workup here, they only said about I think non-Hodgkin's lymphoma in IHC. They didn't tell us about the FNAC that was also done, also the PET-CTs, also the second biopsies, all that. They didn't like summarize all that. It was too summarized. That's what I would say. So it wasn't like giving like a full, like you could not get the full story of the patient just based on the abstract alone. Yeah, so that's my take.
Thank you so much. I think as we've seen before, writing an abstract is not always easy. As much as it looks like the easiest part to do, it's also a bit of an art. So Joy, you can read the chat box. Oh, I've just realized this. It's still set to hosts and and panelists. People are not able to send to the entire webinar. Joy, are you able to adjust that on your end? Or on the chat box, I think there's an arrow there somewhere.
Okay. I'll look into that.
Okay, it's okay. You can
Then-
just
Okay. We have a response from Pamphilia. She says the abstract is brief but well structured. It clearly summarizes the background, case description, and conclusion. The keywords were also nicely written. Those presenting symptom is not a mesh term. Teddy says add mesh terms such as diagnostic error and FTG PET false positive. Lorna says it states the rarity of lymphadenopathy as an initial SLE manifestation. There's use of mesh-aligned keywords like lupus and Kenya. Clarence disagrees with, he agrees that it was short, but he counted the words to be 146. All keywords are also mesh terms. And Irene says the abstract is short but well written as it covers all the important areas, explains the context of the disease, and gives a case description of the key clinical findings of the disease. The investigations and diagnostic workup done is clearly stated as they did immunochemistry, although they didn't mention any other tests done. The clinical course of the disease is explained, and the educational value, which is the importance of developing a comprehensive list of differential diagnosis and the need to consider autoimmune etiologies for patients presenting with generalized lymphadenopathy as the primary symptom, is well stated. The key words were also well put.
Thank you so much. Thank you all for your contribution and for the insight on the abstract. I think that's sufficient for the discussion on the abstract, and maybe our guest editor will add more insight as towards the end of the session. So we can move on to the introduction. So what did you think of the introduction? Did it give a good justification for why this study is, this case report was relevant? And was this rationale grounded in literature? And was it justifiable, and did it make sense to you as you reviewed it? So the floor is open. Anyone who'd like to contribute as we sort out the settings on the chat?
Yeah, I can contribute. I'm Dr. Susan Kuria, the psychiatrist. So in terms of the introduction, the authors outline the clinical background of SLE as a common autoimmune disorder that manifests with a wide range of clinical presentation and the overlapping symptomatology with other conditions, which often poses significant diagnostic challenges. That was well done. Some of the literature cited implies that lymphadenopathy is common among SLE patients. For example, the first citation by Calguneri, what 69%, that really gives an impression that lymphadenopathy is quite common among SLE patients. But I think the authors wanted us to understand that lymphadenopathy is not common, and that maybe that's the reason why it has not been considered in the clinical domain when you want to make a diagnosis of SLE. So I thought this article maybe was really not giving the proper picture that maybe the authors wanted to bring out. I looked deeply into the article, and it was just 100 patients from the ones who had SLE, and 69 of them had lymphadenopathy. And then the ones with rheumatoid arthritis, it came to around 82%. So just this article gives an impression that lymphadenopathy is actually common among SLE patients. Then maybe the authors could have justified that in their setting, that maybe this was the first case of a patient with SLE presenting with lymphadenopathy. That is, if many other cases were not reported previously. And also there's the sentence that several case reports have also noted the potential for SLE to present with generalized lymphadenopathy. So these sentences are actually not bringing out that lymphadenopathy is something rare among SLE patients. So I thought these sentences could have been reframed. Maybe the authors would have reported that despite some case reports and maybe such a study which was done showing that the lymphadenopathy occurs in patients with SLE, that it has not been included in the criteria, and also just try to justify. Then the objective was not mentioned. The last paragraph is not an objective. It's like just an explanation of what they are going to tell us. That is not an objective. So it should have been refreshed to be an objective or an aim. Thank you.
Thank you. Thank you for your insight, Dr. Susan. Anyone else would like to share their thoughts?
I can read a response in the chat. Anthony says then the introduction is good. It justifies the importance since the condition can be easily misdiagnosed in a high TB or HIV setting. It's also grounded in literature. Authors use global studies to show how frequently lymphadenopathy is seen in SLE. Doris says, the introduction highlights the clinical background of SLE well. It has included the complexity of making a diagnosis due to its wide clinical presentation. It highlights existing knowledge on lymphadenopathy as a common presentation in SLE, that's 69% of cases, referencing one study and another on the histological diversity of these nodes that make diagnosis challenging. These two citations are references from global data sources. The objective of the report is to emphasize the need to consider autoimmune disorders as a primary diagnosis in diseases with overlapping symptomatology, which is well explained. Teddy adds, there is need to add regional data or add its absence thereof. And Pamphilia says the knowledge gap wasn't clearly brought out.
Okay. Yeah, thank you all. That was quite comprehensive. So I think the introduction was okay. Now my thoughts is that it was decent. It was good enough in terms of bringing out that gap, showing that it's quite how you always told could it be lupus in the words, and they showed how common lymphadenopathy actually is, and then went on to mention how much it's not actually thought of as one of the top differentials for someone presenting with adenopathy. But thank you all for the additions. So we will move on to the case description. So this is where they state and describe what the case was, basically like a snippet of the entire history of this particular patient. So you can discuss and let us know whether you found this description to be sufficient and detailed enough to inform the readers of this paper, and whether it's useful enough for you to make comparisons maybe with other studies, and let us know whether they included any other relevant supplementary materials, such as maybe histology slides of the nodes that have been mentioned, or any lab data, or just tables and all, and whether ethical considerations were also maybe discussed in terms of how the patient data was handled and everything to do with that. So the floor is open. We encourage you to actually change the setting as you're sending your chats on the chat box. Just send to everyone so that everyone is able to see, so that we all learn from each other, rather than just sending to the hosts and panelists. So anyone who'd like to unmute, you can raise your hand, and then Joy will unmute you.
Yeah, I can go. I'm Clarence. I'm a fifth-year medical student at University of Nairobi. So the case description of the report, to me, it was generally well done, because starting from the beginning, the authors were able to provide the relevant patient demographics, and they're able to describe the clinical presentation pretty succinctly, and the course as well throughout the case report. They're able to note down the diagnostic investigations that were carried out, the therapeutic interventions as well, and the outcomes of these interventions, as well as the follow-up at the very end. But one thing that they didn't do is that they did not include a timeline. They also didn't include any illustrations, which would have been pretty helpful, especially that FDG PET scan that the patient underwent and histology slides. It would have been good to see that, unless it was included and I didn't see it, but I did not see that. And also they did not include a timeline, but most glaringly, they did not include any informed consent procedures. So it's assumed, hopefully they got consent, but they didn't state the procedures. Also, the further explanations on things like Lugano staging and the ACR EULA criteria for SLE would have been nice. Maybe as an image, I don't know if that would be too much to make the report too long, but it would have been nice to enhance understanding. So yeah, but generally it was well done.
Thank you so much, Clarence, for the contribution. Anyone else would like to add to Clarence's thoughts? You can at least have one or two more.
Okay, Anthony again. Okay, I agree with what everything Clarence has said. I, however, disagree just on one thing. I think the timelines, they tried, because you can see a good chronological, like, narrative. Like, first, we can see, like, the patient had TB, first of all, between January to June 2023. And then we can see, like, the first biopsy was done in January 2024 down there. And then I think so. After that, we even saw repeat biopsy again done in July 2024. And then after that, I think SLE, the diagnosis for the SLE was made 1 year after the initial lymphadenopathy. Yeah, okay. There's no like a timeline figure or a table, but I feel like they tried. Okay, yes. So it's sufficient for me. Thank you.
Thank you so much, Anthony. Anyone else? Or maybe Joy, you can read the chat box for us.
Yes, we have a response from Lomi saying the report would benefit from a summarized timeline table to enhance reproducibility and clarity of disease progression, as recommended by the care guidelines. While anonymity is preserved, explicit documentation of written informed consent and ethical approval is not prominently detailed in the provided text. According to the EAJNS ethical standards, such documentation should be clearly stated to ensure compliance. Overall, the case description is sufficiently detailed for comparison with similar diseases and demonstrates acceptable methodological rigor for a descriptive clinical report. Susan says some abbreviations are not elaborated. Wambui says clinical presentation and course has been described, although specific timelines have not been given. That is when she first presented and the duration of the symptoms. Diagnostic investigations, there is mention and results are reported. For the therapeutic interventions, there is mention of treatment. There's mention of the treatment that was offered, classification systems. There's mention that the diagnosis of SLE was made using the 2019 ACR EULA classification criteria of SLE. Outcomes and follow-up, there is mention of follow-up in the renal and rheumatology clinic. Ethical considerations, there is preservation of anonymity. There is no mention whether informed consent was taken, and there is also no mention of institutional approval. Finally, Lorna says, Clarence has described the report so well. Just to add, the report lacks a formal statement regarding written informed consent. Yes, that's it.
Thank you so much, Joy, and thank you to all who've contributed. I don't think there's anything more to add to that. So maybe Najma, you can scroll down. So, because typically for case reports, you don't always need to have like a results section, because the case description is the results. But yeah, so we'll move straight to the discussion. So for this discussion, did it meet the expectations that it will be a good synthesis? Because as you saw in the title, it's also a discussion of the literature review. Did they make a good synthesis of the case and the findings in a clinical context, emphasizing its clinical implications and utility? And in your own interpretation, is this case actually of value to the scientific community, and worth publishing and reading? So once again, we encourage you to share your thoughts on what this discussion was in terms of the impression you got of it and your thoughts as well. Maybe we could start with the chat box this time. Joy?
Yes, this is a question from Lorna concerning the case report. They mention how early presentations make it hard to diagnose SLE, leading to the various tests carried out. So how can we consider SLE that early, or how can we consider SLE that early in diagnosis if tests won't show it in time?
Yeah, that's a good question, I guess. It kind of helps justify the case report, showing how SLE is a conundrum, because it's a great mimic. Because maybe the patient doesn't have the typical malar rash and all, and but I guess the test will be positive. But maybe we'll leave that to the audience. Maybe someone else may give a better answer. But yes, we'd like to have at least two people unmute so that we have a good discussion on the discussion. Anyone would like to contribute and maybe help also give more insight as to Lorna's question?
Okay, my thoughts were on the discussion. Okay, it started well by giving us like a good opening on how on now the central observation that we are seeing where SLE is actually very common. Lymphadenopathy is actually very common in SLE with that 69%. And then I think it also integrated with the already existing literature from the references that were made. And then it also showed like a good, the discussion also said why this is important, because in our country, again, we see a lot of overlap with infectious diseases. There was even mention of Castleman's disease, Kikuchi-Fujimoto. So there was like the whole spectrum. And then after that, it also went on and detailed the pathophysiologic and clinical explanations. It says about, so I think there was even a bit of histology on the different manifestations, lymph node histology in terms of SLE, in even Castleman's disease. So it was very detailed according to me. And then finally, it tells us about the diagnostic challenges in terms of the misrepresentation, or they're calling it about variety, histological varieties in terms of, so you can easily make a diagnostic challenge if you just rely on the histology, and if you just again rely on the PET CT, since it also misinterpreted the results. That's how I would say it was a good discussion.
Thank you so much. That's a very good summary on your thoughts on the discussion. Anyone else would like to share their thoughts? Margaret says the purpose of this case report is to encourage early testing for autoimmune disorders, including ANA, which would include SLE. Yes, I think that answers Lorna's question. Yes, so when someone has adenopathy that's not typical, consider lupus.
The first paragraph of the discussion Sentence 3, lymphadenopathy is a common feature of SLE. Personally, I think I'm having a problem with the statement because I think for case reports, my understanding was the cases should be quite rare and unique. So if the authors are writing that lymphadenopathy is a common feature of SLE, then okay, the impression is like it's not unique. So maybe they should have just changed the wordings to rephrase something like that. Yeah, thank you.
Thank you so much, Dr. Susan. I think I will leave that question to our guest editor, and maybe he will expound more probably on use cases for case reports, because they're not just for reporting rare things. This is a good case report actually, and yes, maybe we'll leave that to Dr. Munguti. So for the conclusion, so this paragraph a good summary, concise summary of the case report, highlighting its utility and its implication? Did they, avoid over generalizing or exaggerating the usefulness of the case in a real world scenario, or the interpretations and the recommendations in the conclusion well tempered for what the case was what the case report actually was? So, and is the case report generally useful? Maybe that has been answered, but yes. And for the references, were they good enough? Were they actual real references? I think, as we mentioned, nowadays we have to confirm references, just do the due diligence, actually check where these references are actually coming from, because in the age of AI, if someone uses that, you easily get fake references that are non-existent. And for those who were the references that were stated used correctly, did they so for example, where the reference has been used, was that what the actual citation actually saying? So, and were they original? Was it a good balance of different sources of literature and all that? So we can have one last discussion on the conclusion and the references. So anyone would like to unmute, please go ahead.
Susan says the conclusion was well written.
Thank you, Susan. Maybe you could qualify it a bit more and maybe say what was good about it. Any more comments?
Yes, response from Mambui. She says, conclusion is consistent with the described data and is clinically useful. There is no use of regional data. So a response from Susan. She says, references 8 out of 13 were more than 10 years old. Clarence adds that 3 of the references were non-existent.
Thank you, Clarence, for the due diligence. I think that's it's a thing that happens commonly nowadays. So, and not many people catch it because no one who actually checks the references that deeply, and you should, in the peer review process. So, any more thoughts?
Yes, so I'm Ian. I'm a second year student at the University of Nairobi. For the conclusion section, I'd say it is well written. It gives an objective view of the aim of the study and in a sort of hindsight approach. I did, however, find that we are combining the references and the conclusion. So for the references, let me just start there. The references, I found that the study does exist for most of them, but it's the DOI that may be the error. So you find that the DOI that if you type into a its web address, you won't find the study. But if you just copy the study and then put it on a browser, you'll find it. So that might be the issue there. But apart from that, I'd say the conclusion is quite well written. Thank you.
Yes, we have a response from Salma saying the references are entirely global or / international. There is no representation of regional, whether African or Kenyan literature, despite the case being set in Kenya.
Okay. Thank you so much. And thank you all for yet another lively discussion. It's been wonderful, and I think we've all learned something. Maybe I think even as future authors, reviewers, and even as editors also, probably the issue with the references was an error on the editorial side. But I think that's it for today's open discussion. I'll hand the session back to Joy, who will now become our guest editor. Thank you very much. So, yeah, thanks.
All right. Thank you so much, Felix, and everyone for your active participation and thoughtful contributions through the session. I would now like to welcome Dr. Munguti to share his views. Welcome, Dr. Munguti.
All right. Thank you so much for this platform. And I should congratulate you first for organizing such a wonderful time. And also tell you are lucky during when you were undergrads and even adding postgraduates, these Zoom things that would make people meet and have these valuable sessions were non-existent. So call yourself privileged for that. Now to my comments, the first thing that I want to ask us is what we really understand by what a critical appraisal is. And again, if you look at the history of critical appraisal, initially came from journal clubs, and the journal clubs was mainly to where in a clinical setup, patient care scenarios. Initially, medical practice was a very individualistic approach, but as the practice became more formalized and people were able to organize themselves into hospitals, and some Englishmen decided to put up a journal club, and it's mainly that's where now the critical appraisal of articles came up, eventually culminating into this thing we call evidence-based practice. And if we look at it, and that's why I want us to narrow to what I feel about this paper, we are looking at a way to systematically and also objectively examine the evidence that we have in research so that we see how trustworthy it is, how much can we trust it, what its value, what its relevance, and how specific in our context it is, so that we can learn something and apply on it. And that's why I want to drag us a little bit away from whether the title is correct, whether the abstract is well written out, number of words. And why? Because every article that you are reading today goes through a review process. And some of the things I had being mentioned here are more of the review process if you are looking at whether it fits a certain channel that's alike. And therefore, the first question I wanted to ask was that what is a critical appraisal? And I always tell my students research, and especially writing scientific papers, it's spreading quote unquote a rumor. It's just that this rumor has somebody whom you can point and say they said this. For instance, the debate we are having here about lymphadenopathy and SLE, lymphadenopathy comes in up to 69% of patients with SLE will have lymphadenopathy. And somebody quoted that, and even the authors of our current paper quoted that. And therefore, that's why I always say, now the question always comes, is it a rumor we can believe? So that we authenticate it and say, it's actually factual. And the first thing that I would look at is the journal. When you are, I remember I was chatting up with one of the leaders of this forum who was chatting me up with this, telling me about that. And the question I asked is, what was the choice? What informed the choice of this paper? And therefore, when you are looking at the evidence, the journal becomes key. I'm part of this journal, and I feel it's a worthwhile journal that we can all trust. Then the other thing that I found that I want to see and feel whether this is something I can trust are the authors. Somebody mentioned about the affiliations, which we agree. University of Nairobi, it's an established public university here. But the other big thing would be, what are their qualifications? That is very, very important. And I always insist on authors submitting papers, give us your qualifications, so that if you are to find this paper was written by a statistician, then everything they said might be picked with a pinch of salt. The beautiful thing is, because we know the authors locally, maybe you say, there are two rheumatologists, so you might believe them. The other question that I asked, and I felt I hoped somebody would ask, is where is the rest of the clinical team? This is a paper with pathologists. This is a paper with radiologists in it, but they were never, or somehow they were lost in the writing of this paper. And that's why we can't ask. And even when you look at the discussion, there is nobody defending why the histopathological reports came as the way they were from an expert point of view. And then there is also nobody talking and defending about the radiological team that gave us a big false positive for a patient who had done an expensive test in the PET-CT scan. This patient was also seen by hemato-oncologists, but none of them was there, and therefore that becomes a key important thing that happens. I found the discussants or the contributors who dwelt upon things that I felt were more handled in the review process, or should be handled in the review process, including the number of words in the abstract, whether the title is correct and the like. For me, those are, because we've already chosen this paper to come and critically appraise it, then becomes important. Now, from the spirit of what a critical appraisal should ideally be, because we are going to assess and see what is applicable for us, what is specific about us, there are things that I picked that I feel needed to come out. And some of the things is, I'm surprised we all believed in this paper. For me, as an outsider, I would feel, where are the histological images? Where are the radiological figures? And when the first presenter was talking, she put some images that were, and you felt like, I even went again to confirm these images were not from the paper. For sure, they are not from this paper. When you say this patient eventually presented with a malar rash and everything, you'd have expected these authors to put that image of that patient and remove any identifiers which were not there. Then they also went ahead to talk about the patient met the diagnostic criteria for the EULA SER score, but you'd have hoped that they had listed, these are the things that she met, and you tick, so that we also learn the scoring criteria for EULA SER for SLE, and then somebody can pick it up and see that. I also found that the others left something important, which was what was the long-term follow-up for our patient. They discharged the patient and everything went out of there. You would have hoped, imagined there are areas that you'd want these patients discharged on this follow-up medications or with this follow-up plan, so that once we've made a diagnosis, then we are okay. Then there are some specific treatment dosages. They just put them not in. You would have appreciated this was given as this dose specific for each of them. So the other thing I felt, the introduction was actually, if you look at it, it's actually longer than the discussion, with some components of discussion evident in the introduction. And I felt they really took long to justify the why of this article, which, as Dr. Kuria has pointed out, I don't know if it's Dr. Kuria or somebody else. It's Dr. Kuria. What's so special about this lymphadenopathy that comes out and somebody feels we need to write about it? So for me, what were the learning points for us? And the first thing is the misdiagnosis. This is a patient who has taken anti-TB medications for 6 months with no relief, actually worsening of the lymphadenopathy. What prompted this misdiagnosis? It was not captured, and the authors did not discuss that bit, even from their history, because you critique everything about in your discussion. You critique what could have gone wrong or what was that, and I felt that was a major issue. And there was diagnostic delays. That's very evident, and they occur everywhere, especially in a patient like this, mwenye ametuchenga. But now, what were the causes of these diagnostic delays? And I felt, especially if here we have enough undergraduate students, the question I want you to ask yourself, what is missing in the history of this patient that would have led you to feel like, look away? What in this girl would have suggested autoimmune disease, for instance? Apart from being 25 years old and being a female, there's nothing else that is given from the history. And I feel the greatest cause of diagnostic delay, and again, the misdiagnosis could have come from that. We needed to have had that. And because of the history that was deficient, I feel now this took the tangent to the evaluation. There are a lot of investigations done, and for sure, even the authors agree or state that this was a diagnosis of chance. After they had given everything, they had even started managing the patient, sorry for I've been muted for sorry for that. So that's the thing. Am I audible now?
Yes.
All right. So the things that I felt the history was missing, and that I feel it's a learning point for us and especially for us who are in internal medicine, then the diagnostic differentials becomes very, very evident. When you meet a lady like this, 25 years old with lymphadenopathy, what things come in mind? And one of the things that I feel was the leader or made this become very, very important was what I would call the danger of an anchoring bias. We are in the tropics, we are a poor developing country, and therefore everything becomes infectious. Everything becomes poverty related. But again, even in the history, we are not told what's the occupation of this lady. We are not told the socioeconomic status that would predispose this lady to the initial diagnosis of TB, for example. So that needs to come out. And the diagnosis of by chance, it's beautiful that luckily enough, this lady, after being treated initially, she developed a malarial rash, things that are consistent with SLE. So for us, I also want us to ask our question, what were the causes of the diagnostic delay once this patient landed there? And then I also want us to pause and ask ourselves, what made the many investigations to be done? And because we are also students, And I know you do exams, and when you do your exams, you are told list investigations about a patient you've clerked or a case scenario you've given. And then you list everything from here to South Africa to West Africa and back to East Africa. So that every investigation you are doing, you are saying it's, and on the defense of the clinical team here, they were actually guided initially by a histopathological report that told them a lymphoma, and therefore they went to rule in and rule out the lymphoma, and the PET scan was initially ordered so that you take out of metastatic disease or the extent of the disease. As I conclude my sentiments, the other thing I would want to ask is SLE, and I want us to go and read the SLE. Then you'll realize it's a disease that goes everywhere and does anything to everything in the body. It's an autoimmune disease that, because of its pathophysiology, you will find it in the brain, and we've met patients with psychiatric-like conditions who eventually turn out to be SLE. We have patients with a chronic cough that comes and goes, persists, and eventually this patient is told, oops, you have SLE, kidney disease, and everything. So let's have that in mind. When you are clerking a patient, when you are seeing a patient with SLE, then realize it's a multi-systemic disease. And therefore, in your history, we need to see you including the systems that could potentially be there, whether the skin, whether the face, neural, whether the lung, the respiratory system, whether the genitourinary system and the like. And in this patient, what would have pointed to an autoimmune disease initially, it's all missing, given the history and definitely the age of this patient and the sex. Apart from these two, the rest are missing. I think those are the points I had about the paper. Thank you, Joy.
No, I don't have anything else to add. Thank you so much, everyone. Thank you so much, Dr. Munguti, for your expert insight and also for also speaking to the students in us to be better clinicians. So this brings our session 8 to an end. We'll share the materials and relevant information about session 9 after. So remember, anything you need is on the EAJNS website. You'll find it there. So till next time.